I'd like to start just by a quick show of hands. I'm just interested in people's kind of level of existing knowledge in this space, so we can kind of adjust to that a little bit. So who feels that they know, a bit about analytics and machine learning in healthcare? You've read a few articles, you're familiar with the terminology, and then I'm going to ask for people who kind of feel like they're pretty much started from scratch, or they'd like us to presume that they were. So who feels like they know a bit? Well, that's really the vast majority of you, okay. And who feels like they're starting from scratch? Okay, not that many, but we'll try and make it kind of broadly comprehensible. Okay, brilliant. I'm just going to kind of, particularly for those of you who know a little bit less, I'll start with a kind of brief scene-setting talk for a couple of minutes. But I'm given that you're actually quite a lot of expertise in the room, I'm going to speak for a little bit less than I was going to, and let the panelists talk a little bit more, since they're far more expert than me. I think the starting point here is, that machines are getting smarter and smarter, and they're doing so incredibly quickly. They can drive cars, understand speech, beat any human player at complex games like Go. This is going to have a massive impact on healthcare. It could allow us to make faster diagnoses, recommend treatments that are more personalised and effective, react to changes in people's health in real time. And we can also make health expertise available to a much broader range of individuals, including half of the global population who don't have regular access to a medical professional, which is a particular focus for Babylon. So there's huge amounts of resource pouring into this field, and progress is happening impressively quickly. So this is going to be affecting all of our lives, and it's an area that Nesta, we're kind of actively researching. We are massively optimists about the potential of this area at Nesta, and really excited about it. But we also want to acknowledge there are some significant issues that need to be tackled before we can realise that potential. The first of which is, of course, around privacy and ethics, that you can't do machine learning without really quite large data sets. And getting hold of those data sets requires either... can you not hear me at the back? Oh, I'm so sorry. I'll speak up a little bit. Perhaps we could, or maybe we can turn the mic up a bit? Okay, how's that? Great. Yes, so there's, of course, a significant issue around privacy and ethics. We need large data sets. And getting hold of those data sets requires either getting consent from very large numbers of people, or anonymization, or a couple of other potential techniques. And neither of those are simple or straightforward, and require a serious conversation about how we approach those issues. Secondly, there are serious concerns around, particularly for the purposes of this conference, the extent to which healthcare remains human, or humanized. And there's always the potential, and you've heard from this morning from people who were passionate about the ability of healthcare to create a system which is more people-powered, but not all technology does that, and that's something that we need to design into the way we adopt any kind of technology in healthcare. And finally, there's a serious question around the accuracy and the regulation that sits around machine learning and other advanced analytics techniques. How do we know that they're accurate and unbiased? And I think it's fair to say that we're very much at the beginning of the process of working out how we do that structurally. So to help us shed light on some of these issues, we're lucky to have with us today some people representing some of the leading companies in this space. And two of our panelists are both from those leading companies, but also previously public servants, which gives them a kind of really interesting and unique perspective on this. We have Will Cavendish from DeepMind, who was previously DG of Innovation, Growth and Technology at DH, and before that held a list of senior positions in government too long for me to go into right now. Then we also have Paul Bate from Babylon, who similarly was Director of Strategy at the CQC, and also held an innumerable list of important positions. And my esteemed colleague Lydia Nicholas, who is a social anthropologist by training and researcher at Nesta, with a particular interest in issues of data and data ownership and public understanding of issues around data. Having said all that, I'm going to start with a kind of a question about where we're going and where we're heading, and what we could get excited about. So I guess what I'm going to ask is, what might healthcare look like in 10 or 20 years' time if we fully develop the potential of artificial intelligence and machine learning, And I'm particularly interested in what it will look like from the perspective of patients and of practicing clinicians. So I don't know which of you would like to kick off. Will, would you want to take that one on?
Thank you. Thanks very much, and thanks for inviting me here this afternoon with my fellow panellists. I mean, I think that the healthcare in 10 or 20 years' time, we can imagine, the impact of artificial intelligence and machine learning will be, I think, very, very significant. When you look at what AI or machine learning does really well, broadly speaking, it's very good at recognizing patterns in complicated data and systems and making fantastic predictions or recommendations about what the right thing is to do. And when you look at a whole different range of healthcare, you can see how beneficial that would be to the NHS in areas like imaging and diagnostics, obviously, but also in diagnosing patient deterioration or the real-time monitoring of patients in hospitals, the understanding of how you best organise and plan health systems, triaging health systems, whether it's in primary care or through personal sort of triaging, even areas like auto-scribing and actions and ordering through voice recognition and voice ordering. You can see all of those things being very significant enhancements of the NHS. But I would say two things alongside that. One is that I think healthcare will continue to be very much led by patients and led by expert staff. I think this will very significantly be augmenting what patients can do to look after themselves and their families, and augmenting how fantastic staff can actually provide excellent and world-class care. And secondly, it's going to take time and should take time, because the introduction of new technologies into things as important as health needs to be done with patients and needs to be done with clinical staff. It needs to be done intelligently and sensitively. And the redesign of healthcare for improvement in any areas, whether it's AI or not areas, rightly has to be done thoughtfully and sensibly. So I think you look forward 10, 20 years, you can see significant enhancements of healthcare. But I think overwhelmingly that'll be done with patients and the staff, as happens at the moment. And it'll need to be done intelligently and thoughtfully to try and make sure the full benefits of AI are brought to bear, for those groups.
So I'd agree with all what Will said. I think though the challenge is you look 10 or 20 years out. I was saying to John, my oldest son is 9 today, so and thank you. But I mean, so 10, 20 years out, going backwards in time, well, I don't suppose my life was in any way something which I knew what it was going to be like now. If I look back in technology terms, the smartphone was just literally being born, and there are 2.5 billion of them now, and there are 5 billion of them projected by 2020. So it's so at one level, it's a question that is inherently unanswerable, and that's one of the most exciting things about it. But I think you can look at some of the characteristics of it. So I think that healthcare is likely to become more democratic, as in globally, there will be more access to healthcare than there would otherwise be. And John mentioned some of the work that we do in Rwanda, but that's just one example of that. The ability to bypass some of the sort of 20th century approaches to delivering healthcare, which is the reality in the developing world. They are looking at what do they need to replicate and what do they not need to replicate. Where can they go straight to a technology platform? That's a really exciting people for a large portion of the world that does not have access currently to high quality medicine. So I think more democratic. I also think significantly more affordable in the developing and the developed world. And I think that's really important. If we look at what is it that actually drives the cost of healthcare, and the two things, one is that it simply costs a lot of money to train the highly expert clinicians that deliver the majority of medicine and care today. That is not a trivial matter for the economics, and of course they incur salaries. And separately, but equally importantly, on the money side of things, if a disease is picked up earlier, it tends to be less costly to treat. You can think of the counter-argument to that, but broadly speaking, that is true. If a disease exacerbates, diabetes is a really good example. If it's managed well by somebody who feels activated and empowered as a person, then the cost of that disease is likely to be significantly less than if it's got into its latter stages. And AI has a really exciting and important part to play in that, as it allows medicine to be more personalised, both at the really the cutting edge of genomic medicine, but also simply being able to pick up individuals' behaviours and patterns and feed back to them what's positive about their lifestyle, given their underlying health and well-being, and things that they can do differently. So more democratic, more affordable, and I suppose the other thing is simply more accurate. In lots of fields of medicine, there is incredible progress. So the stat gets bandied around. There are 11,000 dermatology papers published in a single year. I don't give that as a piece of peer-reviewed literature, but to give a sense of how hard it must be to keep up with your field of expertise, and even harder if you have more of a generalist practice. A machine doesn't have that same problem. And the potential, therefore, to provide more accurate diagnosis, management, and treatment therefore seems to me quite great. So more democratic, more affordable, more accurate, and that seems to be something of really exciting for a world that's growing its population and is seeking increasing equity.
Thank you.
I'll agree with both of you, and then I think it's worth maybe kind of building on that a little to say, in this future where we've looked at we've fully deployed all of these technologies, we're going to see knowledge move quite a lot faster, which means a degree of instability sometimes it can feel like for patients, and that's something that's come across in some of the work that I've done both at Nesta and elsewhere about public understanding, that right now if you're doing data-based work around health and you come up with a new finding or you change someone's health recommendations, it can feel to a lot of people as if they then lose some trust, they then lose some confidence. We're going to need a lot of education and co-creation work with patients, with communities, with people who are coming to a new understanding of their relationship to both expert clinical practice and to tools and to information, to teach them new ways of self-management. And that could go in several different kinds of ways. We find that when you talk to, say, people that are involved in quantified self-work as a hobby, their experience of an incredibly datafied health system is very different from the kind of people who might have type 1 diabetes as teenagers or who might be enrolled in weight loss programs where datafied healthcare is imposed on them in a way. And you see people reacting very, very differently to tools that are given to them in those contexts. So as we move forward with this, an understanding of the fact that humans find it very difficult to engage in the kind of probabilistic decisions that machine learning tends to give us. They'll often say we've got 75-degree accuracy of this decision, whereas a doctor will just say, based on my training, this is the right degree. So they make risk and uncertainty more visible. How you're going to educate patients and clinicians to work better in a new kind of dynamic relationship, so that patients can understand the way the information is evolving, can connect with the tools that allow them to manage their own healthcare, and allow them to maybe self-advocate and to connect with clinicians in a different way. I think
that's absolutely right. And I'm just going to say something I said to the panelists earlier, which is that they should feel free to talk to and disagree with each other rather than waiting in line for me to ask questions. I think if anyone saw my panel session this morning, the panelists ignored me completely and just talked to each other, which I think we can all agree made for a better panel. Could I, just to bring this into a slightly more concrete thing, could I just ask, if there was one problem that you'd like to see solved with AI over the next, whatever time span you like, if you could direct the considerable resources of your organisations to solve something, or if Nesta not being quite so well resourced, Lydia, we'll just imagine that we had a vast resource, what would the problem you'd most like to crack that you think there's tractable in this way and also would make a big difference?
So look, I think the most immediately tractable problem is picking up something you said, Paul, around more accurate. I think everywhere you look, there is just enormous variation in the safety and quality of care, and we know why that exists. It's not because anybody's trying to do bad work or anything. It's just because the mountain of information people have to get through, sometimes the difficulty of interpreting it, there are all kinds of reasons why we're unable to give patients in our NHS the highest quality of safety across the piece. Now, when you look at the research papers that are being published, not just by my organisation or Paul's organisations, but across the piece, in things like imaging, I mean, it's just extraordinary, as you said, the pace that's being made to enable artificial intelligence or machine learning to provide consistently high quality imaging, diagnosis, predictions across all imaging modalities. And I think that'll be one of the first areas where people will have and receive expert level diagnostics, within the next few years, within feasible. And that will be incredible. That will mean every time any of us goes to get a diagnostic test, we will have the equivalent of the world's best person providing that diagnostic, and then, even better, the clinical staff whose time would otherwise be spent poring over these things to figure out what they're predicting will be able to spend more time with each one of us figuring out what's the best way of trying to deal with that particular problem that's being diagnosed. I think that ability to provide consistently across the board sort of high quality diagnostic, virtually costlessly, at sort of marginal cost of virtually zero, will be absolutely fantastic and will be one of the first things that health systems will seek to solve.
Great. I come back to this point about democratizing healthcare, that the single biggest challenge I can think about is people who otherwise, it's not a question of do I go and see the doctor or do I look at my app. That might be our lived reality, but it's do I look at my app or do I access an AI-based solution or do I just worry? Do I just get scared for my health or my children's health? So I think there's a lot you can wrap into that, but for me, this is about you look at the ends, look at what can be achieved. And I suppose it may build on Will's point, but one of the great things I think about artificial intelligence and the machine is it doesn't have a physical boundary in the way that a GP, a really hard-working GP, means can say 2,000 people on their list, maybe even a little bit more. But it's really, it's difficult, and those people tend to be located quite close to them. There's a physical sort of proximity. But once you've developed the machine that can do a diagnosis or can really understand spot the important shadows on an image, that can be deployed worldwide. So I think the thing is to have in our minds, although not just what will it do for our organisation or our locality, but just remember just what the potential is right across the globe if you get these machine-based solutions right.
Fantastic.
I might be being a little too ambitious, but in a way that connects up both of those points. The thing that I get very excited about machine learning being able to offer us is supporting people in articulating and working through what their problems and challenges are, and then and expressing their own priorities and their interests, and then being supported to make the best decisions for them. So, I mean, it's interesting in Babylon, obviously you've got the triaging service, which is, extremely interesting, and is obviously the next generation from things like Patients Like Me, where they had a lot of humans doing that, a lot of clinicians trying to connect up how people really talk about their problems and how they're understood by doctors, and in a chatbot kind of scenario that can support people in articulating what's wrong with them. But also there are steps beyond that which would allow people to talk about, say, their tolerance for risk, their interest in mobility versus communication, in all those different things that when we start talking to patient communities, we find are much more complex and aren't always reflected in what doctors think that patients' concerns are. Like maybe one thing we've quite famous cases, say in muscular dystrophy, where doctors tended to test patients' success in walking for 5 minutes, but in whether their drug regimes and their physiotherapy was working, but actually when you talk to the patients, what they're interested in is whether they can type, whether they can keep talking to their friends and playing games. And those kind of priorities that allow us, that are both responsive to people's interests and connect them up to the latest medical information that allow them to make choices and maybe work through those with expert clinicians when that clinician is available. But that can bring the whole system together like that in a way that's responsive to people's need, I think is really exciting.
Right, I think that point about the way in which people will interact with a machine, a chatbot, or something, the fact that it's different, and there will be lots of cases where people will prefer to interact with a human being, but also we know there are cases where people actually feel they can describe things in a different way, in a way that they have control and power over. Two of the obvious ones for me are sexual health and mental health. Those are things where people are maybe more willing rather than less willing to share. But the bit then adds on to me is that if you get the consent right, if you get the person understands how the information is being used, we get straight past it where you're either sharing with the computer or you're sharing with the doctor. You can be sharing with both. And the thing that I can see, which is amazing, is you can have that really open, honest, what you did last night that leads you to your concern about your sexual health. As long as you know that's going to the doctor that you may be seeing in half an hour, an hour's time, what a better interaction that is. Better interaction for the person who's concerned, because they've been able to voice their worries and fears, and better for the sexual health doctor or sexual health nurse, who now hasn't had to get past all those sort of social difficulties and isn't quite sure what the person is telling them or not. It's a more efficient interaction. It's just a better interaction.
And it adds on to your issue about democratization, in that we find that obviously there's a lot of that we know that socioeconomic and education resources translate pretty directly into the speed of which you'll get a diagnosis and very much to healthcare outcomes. And a big part of that is being able to articulate your needs and concerns and health issues in a way that makes sense to the system, in a way that unlocks the series of gates that are between you and the kind of treatment that you need. If you can explain what's going on in a way that triggers the system to respond, you get access to those resources much better. And we know that apps and decision guidelines that allow people to structure what they need to ask a doctor allows them to get a lot more out of that the 5 minutes that they get with a GP. It allows us to get over a little bit of that bias. And there's a lot of issues, say, around diagnostic bias as well. We know that, say, women's pain tends to be rated lower by doctors, but study after study shows us that that pain from between genders and ages and ethnicities is rated in different ways by clinicians. And if you're beginning that journey using an app, if it's done the right way and if it's done in a sensitive way that is aware of existing inequalities, you can begin to use that as leverage for transformation and make the system as a whole more responsive, more democratic, more equal as in general.
It's a fascinating point, and it tackles one of the issues that concerns people a great deal, which is the extent to which technology dehumanizes healthcare that I'd mentioned earlier. I'd like to pick up on a couple of the other sort of serious sources of concern, the first of which is privacy and data. How do we collect the large data sets that are necessary to make progress in this area while simultaneously respecting individuals' privacy and ownership of data? And what do we, where are we in that journey, and what needs to happen?
Well, I mean, it's fairly obvious, isn't it, that the better the data that's available for research and analysis, across the piece, the better the research analysis is. And that's as true of all kinds of different research, just as it much is of artificial intelligence. So in a funny way, the questions and the issues around data, the important issues around data and artificial intelligence are just the same questions that we have around data in healthcare, more generally, which is the need to keep in balance and reconcile the important protections of personal health data, which absolutely are fundamental, with the ability to, within that context, the ability to, share and link data appropriately that allows this kind of work to go ahead. That's not, as I say, that's not specific to AI. That's a general issue we face. Now, from my point of view, there's a range of things sort of happening in this space that I think are positive and encouraging. So, last year there was the publication of Dame Fiona Caldercott's latest piece of work, which was trying to bring the world of consent and data sharing into a modern footing, but compatible with the Caldecott principles. We still obviously wait for any government response to that, but and so slightly sort of pushed to the right because of the current election. But that seemed to me like a sensible way forward in these kinds of areas that struck the right balance. The thing that I would say that's just a little bit different is the emergence of real-time data, and the value of real-time data, rather than the kind of data that health systems have historically had, which is largely sort of static or statistical or so on. And when you think about what something like MAPS does, MAPS, I'm not saying this is what health data is going to do, but MAPS essentially is a sort of live product that figures out where you are and then in real time recalculates the potholes and the traffic jams and the whatever in front of you, and then nudges you with some action suggesting a pathway that might be quicker than another one. Now, because all of that's actually impersonal data, that's a relatively easy thing to do. But one can see how the emergence of the real-time data capture that we're talking about, could be really beneficial in trying to understand how we can help people support their healthcare. And again, encouragingly, I think people like the MHRA are looking at how we do appropriate regulation of products, devices, apps, artificial intelligence in a world of real-time data capture. And I think the regulatory regime that sort of gets that balance right first is going to be a fantastic place for patients, but also, to be honest, a great place for research organisations and others to develop these kinds of approaches. So I don't think the world of AI is a sort of fundamental rent in the sort of fabric of the universe around data. It's just it's another version of these issues that we need to be constantly keeping in balance, which is balancing the hugely important point of patient privacy, patient confidentiality, patient notification of data use, with the value of those data in improving the quality of healthcare.
So can I pick up on the renting of the universe point? So I think you've covered off their individual consent, which was a really big part of privacy. But I also think there's something we can learn from sort of the societal consent to do things, which is a big issue in healthcare, well beyond AI. But I start my journey in data and analytics is pretty sort of 20 odd years ago. I was doing a PhD in particle physics, and although there aren't the same issues around your own personal data consent, there is still an enormous amount of funding to drive an intensely information-based approach to discovery. And I think the truth of it is, if you're asking people to publicly fund things, whether it's fundamental science on particle physics and the beginning of the universe and the rest, or it's your own healthcare, we do well, I think, to pay as much attention towards people's individual consent, hugely important, as to also just understand where society is and how do you galvanise and excite people about what the potential is. Now, you may disagree or agree with the fact that physicists are inherently an exciting and vibrant bunch who communicate their messages with aplomb. But there was a moment a couple of years back when, with the discovery of the Higgs boson. Whether how many people in the room would really feel they could explain the Higgs boson to other people is entirely another matter. But I think there was a sense that something had happened. We had made a step forward. When you think back to the 60s and the space program, there was a huge global sense that the world had gone forward. And part of this is about society as a whole seeing the possibility as well as seeing the risks. And I think we need to keep balancing those two things together and keep looking for what can we do to solve some of the huge problems that we have and challenges we have in healthcare, just as we do in other spheres of research.
I think I'm going to build on that a bit more and connect to some of the programs that we've already heard mentioned today. So talking about the way that communities, once they have some control over information that they own, are able to steer research. So talking about the drill program that Sally mentioned, where there was a fundamental shift in power and understanding because the disabled people were working to define research priorities, and they were working with clinicians and researchers to work out what they wanted to talk about and where they wanted funding directed. Similarly with Sharon's PecorNet, and particularly the work that she's done with Genetic Alliance and biobanks, the enormous shift that you see once rare disease groups own their information, their tissue samples, their registries, that allow them to work with researchers in a different kind of steering pattern. And when you see big data used like this, where we know from the kinds of stories that we hear from policing use of AI in the States, which is one of the most kind of obvious and advanced examples of people using data very fast to speed up really urgent societal challenges, and realizing as they look back at it that there are deep biases and deep problems in that data, and that they're perpetuating discrimination, that they're answering perhaps the wrong questions sometimes, sending police officers to where they think there'll be crime. So of course the police officers find more crime, which means that you then send more police officers to that criminal area. And they're realizing that there needs to be work with qualitative kind of researchers, hooray, hire more anthropologists in your data companies, and with communities to work out what the questions are that they want answered, what the priorities need to be. And yeah, I think that big data and AI are ways that we can speed things up in either direction. And it's great that people are already thinking about connecting with people and thinking about those societal challenges already.
I mean, I'd love to dig more into the privacy stuff, but I also want to get to questions as soon as I can. I'll just offer one brief thought, just building on what Lydia said about what we've been trying to do at Nesta, which is to kind of link to the talks that you heard earlier about social movements. So the solution that we'd love to see and that we're working to kind of support people to achieve is one where research becomes increasingly driven by citizens, controlled by them, and where they volunteer to give up their data. And it does require this kind of mass engagement. And in our individual interactions and with people who are living with significant health conditions, we find a huge amount of untapped enthusiasm around putting their data forward as partners in research, where they're confident that it's being put to good use and is secure. And you look at research participation rates for a wide variety of conditions that are heavily researched, they're extremely high. So there is enthusiasm out there, as opposed to a model which is really where we kind of start from a position of some distance from individuals and wonder what we're going to do on their behalf. And so I hope that we hope very much, and that turns out to be the way forward. But this is not an area that has a kind of simple and easy solution. So I'm sure we'll come to that in questions. I'm going to ask a final question of our panel, which I'm going to request that you answer quickly, and then we'll get to Q&A. So really, I guess, what is it that if you could pick one or two actions that need to be performed to maximize potential and minimize the downside in this area, what would it be? What would you ask people to do, go away and do, both people in this room and people who may be holding on to levels of power? Some who may be in this room. Hands up if you're holding on to a level of power. No?
Power isn't a lever anymore, I don't think. It's more a cloud, I'd say. My personal experience. Anyway, I think it's touching on some of the issues people have been talking about already, which is this sort of public settlement around the evolution of healthcare. People feel so powerfully and strongly about it, and there's a whole set of sort of questions that we've touched on already, but that include things like the fact that we accept that people, professionals can get things wrong. For example, we have professional ethics and codes in order to look at that, but we demand perfection from machines because if a machine gets it wrong, that's considered to be completely unacceptable. Now, that may be the right approach, but we just we don't have a sense of confidence or settlement around that issue. This question of empowerment, people's ability to understand what the decisions that are being taken and why they're being taken, that really, really, really matters. This question of patient consent and patient data, obviously, which is fundamentally bound up with confidence and trust and transparency and interpretability. All those things, are big questions, and if we manage to collectively come to good answers to those, answers which we feel as a society confident about, then I think we'll see a lot of benefit emerging in this area. By contrast, if people feel very very worried about things, they feel they don't understand them, they feel disempowered, they feel disenfranchised, or they feel taken over in their lives, then we know the response to that is to call a halt. So, for me, there's all kinds of technical questions that we can sort of figure out and sort out and solve. But in the end, we need to be, as a society, confident that we understand the progress of these technologies, feeling that we have some say in those, and that what's sort of happening both to us and in our NHS is something we're confident and happy with. So those broad social questions and social confidences, I think, are completely vital.
I've also got to be fairly quick, so we've got time for Q&A.
Sorry.
So for me, I think it's two things, but it's a give and a get. So I think the thing for everyone is this willingness to innovate, to dare to dream big, and I think that's what's been behind the big leaps forward in all spheres of life and in healthcare. Within that, if we don't dare to think what is the possibility of genomic medicine. What was the possibility of precision surgery? Whatever your preferred thing in medicine is. If we don't dream it, we don't think it through, and we don't deliver it, by definition it doesn't happen. But I think the flip side of that is that anyone who's working, Will and myself and lots of people in the room in AI, is the commitment to transparency. The new, I think, is often seen as something that could easily be hidden from people. So the willingness to publish both what you are doing and the results that it is happening, to not stay silent. It's very easy, and it's easy on this platform, to say nothing at all. You be the judge, right? But unless we are out there publishing our results, saying how our symptom checker is doing, and unless we're telling people what we're going to use an investment that we get to do and why it's exciting, then I don't think it's fair to ask people to dream and believe that it can happen. But I do think those two things come together.
Yeah, and I'll be very quick. I just think that the key thing is always to bring people with you, and that's often by convincing people of the business case within the NHS and within the system of the benefits, but also about telling compelling stories that illustrate these sometimes very complex ideas. I've worked in focus groups trying to do some research into public understanding of data collection around the country for the Wellcome Trust. And one of the things that struck me was how big of a deal Angelina Jolie's mastectomy was. Everyone who understood about genetic causes and risks referred to that story. So many of them could not understand a lot of what we were talking about. People would deny the existence of inference and statistics to my face, which is really quite stunning when someone says, you can't understand anything about me by studying other people. Are you God? That means nothing to me. And the understanding of risk and statistics is relatively low in the population. But if you can tell a compelling story that says, look, we understand this about something that runs in the family because we've been able to do this kind of research, because some people shared their information. And you give a lot of transparency that allows people to dig into that story if they want to think about what they would do in that circumstance. People are actually incredibly generous, especially if, as Mo said earlier, once you give the patients the data, often that's the work done for you. They then want to see this research happen. They want to see things move forward, so long as they're kept in the loop, so long as you keep telling them stories that make sense, so long as you're transparent when sometimes things go wrong. So that's it. Tell stories and bring people with you.
Wonderful. Thanks, Lydia. So, right, let's move to question and answer. I'm going to take two at a time. Gentleman right at the front here, and then lady in the white coat there. And then I'll take some more from around the room. Could we please tell us who you are, and please keep your questions as short as you can.
My name is Maurice Hoffman. I'm not on yet. My name is Maurice Hoffman, and I serve on the Research Ethics Committee. And only recently there was an organisation set up to basically have a registry of a well-known disease. Now, out of this, what's happened? So one, there was no people-powered health because the database wasn't being controlled by patients. Secondly, whilst we put in individual data, who owns the collective knowledge afterwards? And this has been brought up in terms of DeepMind, when I've heard clinicians say, we like to know the algorithms. And we also know, I was attending a meeting at MHRA last week about diagnostics and data, that the actual machines don't often change, but all the time the software is changing. And as far as I've been hearing, there isn't much supervision, if at all, on the changes. So I don't see much people-powered health, and I think we do need a new paradigm where we also need to know, the last thing is this, people probably willing to share their data within Britain and the NHS. But if we go into elsewhere, who controls it? The United Nations or WHO? It's not clear. And if it's in private hands, then there's private gain.
Thanks very much.
Sylvia Wyatt, I'm advisor to the Age UK on the Isle of Wight. What I'd like the analytics to be able to tell us in the future is what is the normal me, to monitor what I'm like when I'm doing what I can for myself. And rather than, so that's the aim, what is normal me, so that it can trigger when I'm unwell.
Great, thanks. So we'll take those quickly and quick answers, please. Really quick this time, panelists, please. So we have a question about who owns the data and the algorithm after the work, and also what about the ongoing evolution of the algorithm over time? How does that get validated repeatedly? And what about the data getting moved overseas? And finally, and what about normality? How can we make people's normal states more visible to them? So you don't have to answer all four of those.
Well, let me just try and very
Why don't you
quickly.
pick the one that was directed at you?
So let me, the question of real-time changing algorithms, data, and so on and so forth. Just to be clear, DeepMind as an organisation doesn't have any of its own algorithms deployed in the health service anywhere in the world at the moment. So if what you've seen is definitely not something to do with us. The issue, though, you're absolutely right. We are going to need regulatory agencies that figure out how you do that. How do you make sure that the improvements that can take place as a result of these analyses can be properly overseen, regulated, and made safe and secure? You're completely right. And as I was mentioning in my comments, MHRA has already said it's working on this, and I think that's fantastic work to be done. On the question of data transfer, it's of course illegal to transfer patient data outside the United Kingdom, and no organisation should be doing that, identifiable patient data. And certainly, I can guarantee that DeepMind doesn't do that. I'm sure same for Paul as well. On the question of who owns algorithms, I mean, there's a very similar process or question to who owns a piece of medical equipment or who owns a medicine. Obviously, organisations, not just private organisations, invest in research and development. They develop stuff that people find it's useful in the health system. Those people purchase those products, and there is some ownership over those products. The question is not really about that. I think the question is going to be around fairness of pricing and how we make sure that the things that are being developed are useful and usable within health services, rather than whether or not an organisation that has invested considerable sums in developing new knowledge has some right to use that knowledge.
Thanks, Will. I'll ask someone else to pick up on the question of the normal me. Do either of the two of you feel like jumping into that
I
one?
can give it a go. Yeah. So I think that's just fundamentally, it's a great way to think about it. Most of the time, for most people, they certainly, most people are broadly healthy, and whether you are or not, or whether you perceive yourself or not, you perceive yourself in a particular way. So I think one of the great things that AI's got to do to be successful in hunting the people power, the activation, is create a version of self that people recognise. And the corollary of that is that then people feel they have control over. So one of the things that we talk about, and we're busy building as well, is taking on a whole bunch of information with consent around apps and wearable devices, so that we can play back to the person using Babylon, this is how it looks, this is you. This is you. It's an avatar of you, if you like that sort of visual form. But the point, this is you, and you know, it's a great day. You're doing all the things that you said you wanted to do, behaviourally or health-wise, and when there is variation from that, then it can alert you to that, and it can suggest things that you can do about that. But I think the touch points of recognition and control.
Great. I'm going to take three questions quickly. There's a gentleman on the table there, gentleman there, and a lady in a red coat there. So I'll try and get back to you at the end.
Thank you, Andy Hadley from Dorset. I was interested with something that Will said around errors. And obviously, one of the hopes is that the machines will reduce some of the random errors, the unwarranted variation. But it does kind of mean if the algorithm gets it wrong, then it gets it wrong for every patient. So I was just a bit worried that you were sort of suggesting that we should be tolerant of errors in machines.
It's a very fair point. Should we take Eddie the code there?
Kay Oliveri, Imperial College Health Partners. Lydia, your insight into the human factors linked to digital health is so refreshing. I really do applaud you. Can you give me some pointers in terms of how to have the people-powered health in terms of engaging patients and the public from the very early design stage right through to implementation?
That's a quick question. I think last time we did a whole session on that. Jonathan over here.
Yeah. So my name is Tim Walliscroft. I'm a member of the co-production group of the Coalition for Collaborative Care and a PhD student at Sheffield Hallam University. My question is, if you accept the fact that all data is biased because there are power interests in deciding what data is and what data is not collected and so on, then how do you factor that into predictive analytics and machine learning and artificial intelligence? Because ultimately, if someone's faced with a statistic, well, they might assume that statistic is neutral.
Great. 3 great questions. Lydia, can you answer that question succinctly?
I'd say that it might be a good idea to look at Nesta's entire publication history. But one of the things that Sharon's quite a role model to me in this, in that she, as other health activists have done, have taken steps that mean that the patients and the communities have real power. There's no way for you to have tokenistic involvement when your patient community owns the patent to the gene. There's no way that you can dismiss their input and sort of have ticked that box if they actually own the biobank or they own some of that data. Some of that can be done by enshrining things in legal rights, which was something that Sally mentioned about these things being written right into legislation. And we've seen that in some of our health as a social movement research, where people, particularly with conditions that are stigmatized, which I think would translate to some of the issues that we see in discrimination in design in data work, are able to reference laws that say that they should have access to excellent care and they should be involved in decisions about them, that if you fail at that, they have the ability and the right to challenge that in law. So I'm not going to start talking about the practical programs from beginning to end. I just think that if there are ways to enshrine that in a system that means that you cannot fail because people have a legal right or they have ownership to those systems, that puts you in a really great position for making sure that you're doing true co-production and not something tokenistic.
So I'm going to crash these last 2 questions on errors and bias together, if I may, and ask one of you to pick up on that, because I want to try and squeeze in 1 or 2 final questions.
Well, let me pick up. I was asked directly the question around error. I was thinking, actually, not of what you quite described. I was thinking about the occasion when a self-driving car killed somebody in the United States. Now, in the United States, several jumbo jets full of people sort of die every day just on the roads through human error. But, of course, partly because it's a new technology. I think it was Tesla. One Tesla went AWOL and unfortunately killed somebody, and that was, of course, front page news. Now, as it happens, in that case, they identified the software error, and they could upload that software change overnight to every single Tesla. I'm not trying to advertise for Tesla, by the way, because nothing to, I have no knowledge of the company whatsoever. But it was just an example in that case. I was just thinking much more of the differential approach to those things that we have as a society, and how we're going to just have to figure out how comfortable we are in a sort of different world with how we approach those kinds of questions. Obviously, one of the great advantages of AI and machine learning is its ability to genuinely systematically reduce errors across the piece, but actually also flag up when the agent or the model or the machine actually can't make a prediction in a much more systematic way. So I think there'll be great potential to do that. But it'll go back to the processes of systematic evaluation, high standards of research approval, independent evaluation of outcomes, publication of data, all of those things which we have generally in the scientific world to try and improve the quality of what we do will need to be the same again. But there's still at the moment this sort of differential feeling about things. That was what I was mentioning.
Great. Quickly on bias, if that's not been covered.
Yeah. Is all data biased? I think I see what you mean. But I also think if you take that paradigm, then I think it's hard to see the thing that isn't biased in life. So I think in that respect, AI is nothing special, and that's important. So I think the lesson to learn is what do we do in all fields where these biases creep in? And I think there are two things. So one is you apply the disciplines of research, one of which is you look so carefully at biases and you go for peer review and all those other things. You do the things that you can to challenge your preconceptions and your potential biases, whether they're in your humanity or in your data. I think the other bit you do, and we do this a lot, is we don't put machines in opposition to medics. We collaborate. We do the two things. All our algorithms are developed, vetted, tested by clinicians who have an incredible ability to spot patterns and to hang on, that's not right. Why is it taking us to this answer? So I think you bring in the best of what you've got, and the watchword, I think, is to learn from what other people are doing and not to pit a machine against a human in an aggressive way, but to learn from the best of both.
Great. Fantastic. I'm terribly sorry, but we don't have time for any more if we're to keep to the timetable. I'm sorry about that. But I'd just like to end by thanking our panelists, Lydia, Paul, and Will, very much indeed for one.
Yeah.